anesthesia and bispectral index and effect site concentration values.
Yes, I did.
And one of the authors is your friend and colleague, Dr. Paul White, who's seated in court here today?
That's correct. This is one of Dr. White's papers.
All right. And on what did you take away from this article, what finding that you included in your modeling?
In our model in volunteers, we did not specifically look at a concentration in the effect site in the brain for apnea. Where do people stop breathing? And I needed that number to do the modeling because apnea is the effect that we're very concerned about. So I turned to Dr. White's paper for the number that explains apnea. At what concentration, at how much drug in the effect site in the brain, how much drug in the brain, what's the concentration of drug in the brain where a person may stop breathing? And Dr. White's paper provided that information.
And the drug being propofol.
And the drug is propofol.
Is this, and I'll get to another slide where it may be clearer, but is this slide documenting one of the tables from Dr. White's paper that provides the information of when, at what drug concentration of propofol one would be at risk of apnea or stopping breathing?
Yes, it does. This is a table, and down here is the occurrence of apnea for propofol, and this is the effect site concentration in this paper that was associated with apnea for propofol. Where do you stop breathing?
And this actually says to the left here, occurrence of apnea, and beneath it, propofol?
Correct. They looked at two drugs, propofol and thiopentol. So you can see here thiopentol is below it. But for our purposes here, the drug of interest are the numbers for propofol.
And this column that I'm pointing to, which would be, as far as the data, the third column of data over, what is shown in this column?
That is the effect site concentration, CE. The E stands for effect site and C stands for concentration. So CE, concentration in the effect site measured in micrograms per milliliter.
Okay, and for propofol, then occurrence of apnea, according to this, is at 2.3 micrograms per milliliter, and then it says plus or minus 0.5. Is that accurate?
That is correct.
So what does that mean?
2.3 is the number at which half of patients would be expected to be apneic, not breathing. But every patient's different. And because every patient's different, Dr. White has provided a range. And that range is plus or minus 0.5, and that's called the standard deviation. So if you want to get the full range, you usually use 2 standard deviations, which would not be 0.5, but 1.
And why, I'm sorry, why do you use 2 standard deviations?
2 standard deviations will basically account for 90% of the patients, 5% off at either end. So you can account for the most sensitive patients and the most resistant patients within 2 standard deviations.
And the use of 2 standard deviations, is that the custom in this type of research?
Yes, it is.
So the range, according to Dr. White's article, the range at which someone would be at risk of apnea after taking propofol would be between 1.3 and 3.3 micrograms per milliliter.
At 1.3, you have 5% of patients at risk. At 3.3, 95% of patients are at risk. It's not like you could go higher and be breathing fine. What that range actually tells you is where you transition from a couple people being at risk to everybody being at risk for apnea.
But the total range with that explanation would be between 1.3 and 3.3 for being at risk of apnea as a result of propofol.
Well, above 3.3, everybody's apneic.
Before we get into the modeling, going to this next paper, combination pharmacotherapy improves neurological outcome after asphyxial cardiac arrest. What did you take away from this article as it is reflected in some of your modeling and conclusions?
A key aspect to the modeling you're going to see is how long does it take after a person stops breathing for circulation to stop? Because propofol's pharmacokinetics are so fast that if the circulation keeps going, the drug goes away. As long as the heart is beating and there's circulation, there's propofol metabolism. So the question posed here that this paper addresses is, what is the delay between no longer getting oxygen? And this is a study in pigs, because this is not a study you would do in people. And these pigs were breathing, first they were in fact anesthetized with propofol, which is kind of useful and appropriate. And at time 0 here, their breathing tube was clamped. Exactly what would happen if your tongue fell into the back of your throat and you couldn't move air. They had a breathing tube in and it was clamped. They were on room air. They were not getting extra oxygen. They were on room air. It took 9 minutes to go from the clamping of the breathing tube until the heart stops beating. Were propofol in the animal, there would be 9 minutes of metabolism until finally metabolism ended. Then there's additional aspects to this study, because this is really a study of cardiopulmonary resuscitation. So there's a delay, sort of the paramedic delay here until they get to the scene. And then there's a few minutes of CPR. This is defibrillation at this point, and this restoration of circulation at the end. This is a study on cardiopulmonary resuscitation using a pig model. But from my perspective, the key data was the time delay between when do you stop breathing and when does circulation stop, which is when propofol metabolism would stop.
And in your simulations, did you use a number of 10 minutes?
Yes, I did.
Compensating for it being a human larger body weight?
Yes, the larger the animal, the longer it takes, because there's just simply more lung volume. There's more oxygen in the lungs for a larger animal. These are 20-kilogram pigs, so that it's actually, relative to a person, it's quite a small model. So the number that I used in my analysis here was 10 minutes, also reflecting the fact that Michael Jackson was on supplemental oxygen. And by being on supplemental oxygen, it just takes longer for the lungs to run out of oxygen, because he's breathing more in each breath.
And just to be clear, what is asphyxial cardiac arrest?
Asphyxial cardiac arrest is when the heart stops beating because of lack of oxygen. There are a number of reasons for the heart to stop beating, including a heart attack where the blood stops flowing, or something called a pulmonary embolus, which is basically a big cork that goes into your blood system and stops blood from moving. Asphyxial cardiac arrest, asphyxia means lack of oxygen. If you drown, it's an asphyxial arrest. You don't get oxygen, and that's the primary problem. So this is exactly the right model for what we're talking about here. The heart stopping after oxygen has stopped going into the lungs. It's exactly the right model to understand the time course of circulation in Michael Jackson after he stopped breathing.
Now I want to talk to you then about the actual simulations that you conducted in this case. And is it fair to say that you went through a number of potential scenarios to determine if they in fact were supported by the data in the case?
That is correct.
And is it fair to say that you were able to, based on your expertise and the evidence and data in this case, you were able to reject a number of potential scenarios?
That is correct.
Going to this first simulation entitled Propofol 25 milligrams, you're aware that Dr. Murray in his statement claimed he gave just 25 milligrams of propofol, correct?
Correct.
And does this model depict the relevant findings if one was given just 25 milligrams of propofol?
Yes, it does.
And can you please, as you did earlier, walk us through what is depicted in this first model?
So I'll be happy to do so. On this axis down here, we have the number of minutes since propofol was given, because now we're talking very small time courses, what happens over a period of minutes. And this shows the propofol concentration up here. Now there are two lines here that need to be explained. This is the femoral vein concentration of propofol, 2.6. That's what was measured on autopsy.
And that's actual drug level of propofol at the time of autopsy in the femoral blood.
Correct. That is the drug level of propofol taken by the coroner from femoral blood during the autopsy examination. This other line is the apnea threshold from Dr. White's paper. So that's the apnea threshold of 2.3. That's the concentration of propofol in the effect site, in the brain. That's the concentration in the brain where half of patients would be apneic. So we see that the level of propofol in the femoral vein is very close to the level of propofol where apnea is expected. Now, I mentioned the importance of distinguishing between the blood concentration and the brain concentration. And that is really emphasized by this slide. When you first give that injection of drug, and you push that in, the blood concentration itself is very high, because all that drug is in the blood. So you start off with this very high concentration. That concentration descends incredibly fast. Incredibly fast. The reason it goes down so fast is two. First off, as we've mentioned already, the liver eats, metabolizes all of the propofol that goes through it. So as the concentration, as this large amount of drug hits the liver, it's metabolized. But the other thing is propofol quickly moves into tissues. And propofol is basically fat. It's a very, very fatty molecule, and it loves to go into fat. So propofol is not only being removed by the liver, it's being removed by the tissues in the body, particularly the fat tissues in the body. And so that's why the levels drop so fast. Now, this is the brain concentration. It takes time for the drug to get into the brain. The brain concentration initially is 0 after you give that bolus, but over about 2 minutes, minute and a half, 2 minutes, it rises and reaches a peak. And by the way, it's not a coincidence that the peak occurs when this curve crosses this curve. After the peak, the brain levels fall slowly. And you'll notice that they fall more slowly than the blood levels. The reason is that the drug has to move out of the brain in order to be metabolized. And the speed of drug moving in or out of the brain is the difference between these two lines. So right here, I would call it a gradient. There's a big difference. There's a lot of propofol outside the brain and no propofol in it. And because there's so much outside the brain, it's really pushing itself in. However, on the other side of the peak, there's propofol outside the brain and propofol inside the brain, and it's not so different. So the transfer is a little bit slower, because propofol basically moves down what's called a concentration gradient. So for our purposes here, if we were to look at the blood concentrations, boy, you'd think everybody was apneic. But they're not, because propofol doesn't work in the blood, it works in the brain. To understand what's going on as far as apnea goes, you follow the solid red curve here. Concentrations rise, they peak, and then they fall. And you can see that we are, even at our peak, we're below the point at which, based upon Dr. White's work, half of patients would be expected to not be breathing.
What is this gray area on this model?
I've now here added the 2 standard deviations in each direction.
From Dr. White's
From
research?
Dr. White's work. And it says that below this edge here of the gray, nobody would be apneic.